relative to research in rare neuroimmunologic disorders. So I get to start off this session, so I get to introduce myself. Hi, everybody. I'm joining you from the UT system, the children's system, and I'm here to talk about what have we learned from the CAPTURE study. By a show of hands, how many people here know what the CAPTURE study is? If you are actually a coordinator or worker in the CAPTURE study, put your hand down. Now, of the rest of you, great, and that was, I think, one hand. So, Dr. Harder referred to this in her talk, but I want to go ahead and take the poll. Out of those in the audience, how many of you, either for yourself or a loved one, was told your loved one will probably not walk again, by a show of hands? Maybe 20%. What about whatever you get in terms of recovery by a year is all you're going to get? Now we're at the 50 to 60% mark. What about, this is my favorite, this is your new normal, accept it. Oh, now we got some more hands, okay. How many, when you or your loved one were going through the acute episode, were told, we don't know what the right approach is, what the best therapy is to handle this? Okay. So these are all common themes, and we've been doing symposiums now for how long officially? Almost 20 years, let's say. We're a couple years away from 18 years, and these exact same phrases are 20 years old, which is somewhat disheartening in some respects, but what we're going to talk about is how things are changing. So, how many people here, when approaching their clinicians about possible other therapies beyond steroids, plasma exchange IVIG, were either met with quizzical looks or told, we don't know if that works or not, or whatever the case may be? A few. So, to date, this is in big, bold, 40-point font, there have been no large-scale prospective studies of the outcome in transverse myelitis. Let's just absorb that for a moment. Everything that is published has been retrospective. Everything that is done has been through chart review. There has not been a single large-scale prospective study to say what happens to people who are diagnosed with transverse myelitis. Now, why do we care? Is it just for education's sake? Is it just so that we can say what works and what doesn't or what the outcome is? And the answer is no. It is extraordinarily important to get the prospective large outcome database put in order to design interventional clinical trials and in order to answer the questions what actually works and what doesn't, or which patients benefit from therapy A versus therapy B. Without a data set around outcomes, it is impossible to attract investment from biotech companies or pharmaceutical companies or the NIH or anybody else to design interventional trials, because the first question they ask is, what's the natural history? What actually happens under the current state of treatment? And we have to rely on things like, my favorite, oh, the outcomes are, let's see, who can give me the answer, divided into a third, a third, and a third. A third don't get better, a third have a little better, a third have recovery. Anyone here heard the third, a third, a third? It gets perpetuated over and over again, and we haven't had any data prospectively gathered to try and refute that. So the CAPTURE study was our attempt to try and change the course of this. So it stands for, CAPTURE stands for Collaborative Assessment of Pediatric Transverse Myelitis, Understand, Reveal, and Educate. And so for anyone who's in the UT system, they all know one of my favorite things to do is whenever we're designing a new study is to try and come up with a fun name to title it. So we've got Aperture, we've got Capture, we've got all sorts of things. But at its core, everything that is involved in the study is encapsulated in the title. This is truly collaborative, and we are really trying to understand the underpinnings of what happens to individuals, specifically children, who have been affected by transverse myelitis. This was funded by the Patient-Centered Outcomes Research Institute. For those of you who were in the session earlier today, you heard me mention it. How many people here are familiar with PCORI, or what this institute is, by a show of hands? 1, 2, so 3. So the Patient-Centered Outcomes Research Institute was part of the Affordable Care Act funding. So for many years, lots of different stakeholders said the way we're designing clinical trials isn't the best because it's a bunch of clinicians and scientists and pharmaceutical companies and NIH sitting around a table designing a trial, and there were no patient representatives sitting there to decide is this being designed in a way that's actually meaningful to me? Are you measuring the right outcomes? Are you doing it in a way that will actually change my level of care? And so the PCORI initiative was funded to infuse capital to do research differently, to take the patient's point of view relative to outcomes and put it at the forefront of research. So we used the PCORI funding mechanism, we applied and were granted the funding for the CAPTURE study. So this becomes the first federally funded transverse myelitis study, outcome study in history. This is a multi-center study looking at pediatric transverse myelitis, and it had 2 cohorts. And let me explain the in-person and the online cohort. So the idea was that we would recruit families who had had a child afflicted with transverse myelitis at any point in the 6 months prior to the recruitment into the study, and they would fall into one of 2 categories that they could pick. This was not randomized. So they could elect to be part of the in-person cohort, which means they would have to be seen at one of the collaborative centers around North America to get assessments, or if they could not follow up in person, they were invited to take part in an online cohort. Now, both cohorts had to send in all records related to diagnosis, their MRIs, et cetera. In the in-person cohort, they had regular clinical assessments to measure what are the outcomes after the acute event, but both groups provided patient-reported outcomes. And part of this study is to sort out how good are our assessments lining up with what patients are reporting. And it is always interesting when we diverge. When we say, oh, you look great, but the patient says, really? Because it's not going so well. Or vice versa. The patient says everything's going fine, and the clinician says, this is a disaster, what's going on? And so looking for where we overlap versus not is important. So the clinical assessments and the data gathering occurred at baseline, 3 months, 6 months, 12 months, so going out a year from the event. And we gathered whatever MRIs were available, whatever spinal fluid studies were available, and then for the in-person cohort, we did assessments of muscle strength, gait measures, and functional measures. You'll see me refer to in a little bit something called the FIM and the WeFIM. These are outcome measures that look at total function. Not just are you able to walk or not, but how independent are you in your life, and it's based on your age. So obviously, the independence of our 8-year-olds versus our 18-year-olds are different depending on the 18-year-old. So the collaborators, this was multidisciplinary in Dallas, our colleagues at CHOP in Philadelphia, both the Kennedy Krieger Institute and Johns Hopkins in Baltimore were at site. Terry Schreiner leads a group at Colorado University. Sick Kids in Toronto, Alan DeSena at Cincinnati. We have our statistical support and data collection from the University of Alabama, Birmingham. And as we get down to the bottom, it should be in bigger, bolder letters. This study was designed in equal partnership with the Transverse Myelitis Association. And so one of the things, frankly, that got us scored so well to get the grant was because we were doing it in concert with a patient advocacy organization. One of the metrics PCORI uses to decide who they fund is it just a bunch of doctors and scientists in a room applying for a grant, or have they really partnered up with a patient community? And if you look back at our scores, those were our highest scores across the board. The input from the Transverse Myelitis Association was critical not just for receiving the funding, but for the success of the study. And I'll talk about the collaboration with Traitwise. So where are we? We've enrolled over 110 pediatric patients who had transverse myelitis, which will make this the largest prospective outcome studies in TM, and definitely pediatric TM in history. The study is still ongoing. It is not over yet. PINs across the United States, and this is a North American study. We do have enrollees from our neighbors to the north in Canada, show distributions, and you'll see clustering really around centers that were some of the sites doing the in-person assessment because they tended to be the most active at referring. As you see pins that are nowhere close to one of the sites, the overwhelming majority, if not all of those, are due to the efforts of the Transverse Myelitis Association. So Rebecca Whitney, on behalf of the TMA, you in the room, parents, support group leaders, individuals who are active on Facebook, you are the first ambassadors that get contacted by families who are going through the nightmares that you have all gone through in the past. A friend of a friend of a friend says, Transverse myelitis, I know somebody with that, and they get you connected. And it was through those connections and you and the TMA saying there is a study you can get involved in that we received a lot of our referrals. And it's been tremendous to see that work happen. So this will be the first public presentation of any of the data from the CAPTURE study. It is still ongoing, so this is incomplete. Dr. Harder did a better job of putting a big caution sign. I will not be drawing any conclusions. Everything I'm going to show you is descriptive to give you a sense of what we have so far. And we are still having families who are in the midst of it, out of that 111, who might be at 3 months or 6 months. So I'm not showing everybody's data. I'm only showing subsets of data. So let's talk about what types of children we're enrolling. And remember, this is all pediatrics. Interestingly, we have slightly more boys than girls, which is not the normal split that's been reported in TM. A lot of studies will say it's equal, maybe a slight predominance with girls versus boys, but here we have the reverse. And there's a reason for it, which we'll discuss. And then birth month. So this is an interesting area of research in a lot of conditions. It turns out that a lot of diseases have an association with the month you were born in. So anybody here born in May? So we have a higher risk of multiple sclerosis. Anybody born in December? So you have a higher rate of living past the age of 100. Anyone born in February? See me after, we'll talk. So for TM, we don't see any clear difference in terms of birth month. We're getting kids across the spectrum. And indeed, in studies that have looked at this in the past, we haven't seen any changes. So that's date that you were born. What about time of year of being diagnosed with transverse myelitis? And what we do see is a seasonal difference in this cohort with a higher rate happening in the summer months. Now, in Texas, summer goes on for 6 months. In the rest of the country, it's 3. But as you go from July, August into September was definitely a peak. And I'll talk about in a moment why that was the case in this study. It is probably a unique feature of when this study was rolled out, and I'll explain what I mean by that. But that's what we're seeing in our cohort, a bit of a peak in August, September. So symptoms at onset. How did children with transverse myelitis present? So in terms of motor function, we had slightly more kids who were having affected lower limbs and upper limbs, but there were a lot of kids who had all 4, quadriparesis or quadriplegia. If you looked at sensory, overwhelmingly when there was sensory involvement, it was in the lower extremities with the upper extremities being spared. And about half of the children had some sort of bowel or bladder involvement, whether it was issues with retention or incontinence. A little over half had it, and a little less than half had no involvement of bowel bladder dysfunction. So these were the symptoms at onset. What about what happened in treatment? So we asked families to report, and we verified in the medical records what treatments were offered. And what's in this graph is the initial treatment offered to the child, and the overwhelming majority of children were given high-dose intravenous steroids. There were a few who, as their first treatment, had IVIG. And if you look at, in the immediate weeks following that first treatment, the individuals who said, I had no improvement whatsoever or minimal improvement, it's about 2/3 of patients. So if you look with the majority of people just getting steroids, it's about 2/3 to 1/3 having little to no improvement versus moderate to significant improvement. When we asked, did you get a second treatment, did you get something additional to the first-line therapy, there's a split in the pediatric world between the use of plasmapheresis or intravenous immunoglobulin, IVIG, and then there was a group of patients who received no second therapy. So after the first therapy, that was it, and they were done. What's interesting is if you look at the individuals who got a second therapy and said, all right, well, after the first compared to the second, there's a shift, and you start to see more than half the patients reporting, and this isn't long-term, this is immediate, that they're seeing moderate to significant improvement with a number of patients having complete recovery, even in the early stages with the additional therapy. There are no statistics I'm applying here, there's no analysis I'm applying here. I cannot use this data to say that certain therapies are superior to others yet. That's the analysis we're going to do when the study's concluded. We have a statistical plan in place with this data to determine, was there a difference in outcome in children who got IVIG versus not, plasma exchange versus not, 2 therapies versus 1 therapy. So back to that question that many people asked their clinicians, beyond steroids, should we do anything else? We will try to give some actual evidence-based medicine guidance to the field on what happened in a prospective cohort. So what about the outcome? So going back to a third, or whatever you get at a year is all you're going to get, or your child's never going to walk again, this has actually been the most heartening part of the data that I've had a chance to look at. So remember I noted that FIM or WeFIM score, which is a measure of independence. It's got a lot of different modalities involved: self-care, bowel bladder, grooming, movement, feeding, all of those things. The higher the number you get, the more independent you are. And so I'm not applying any statistics to this. This is just qualitative, but just by eye, you can see that a number of kiddos who are going out 6 months to a year are having good recoveries. They are becoming functionally independent. We are going to break this down into subscales and do the analysis. And what we want to see is get everybody off to the right of this graph as possible. So what about the timeline? How did this start? What have we done, and where are we going with it? So the award, the grant, came in 2013. The contracts were set up in 2014. You got to get the lawyers involved to get the language right. We had our IRB approval in the spring of 2014. The enrollment opened in the summer of 2014, and I want you to remember that for a moment. We're going to come back to it. The PCORI funds will continue through next summer. So this July, the PCORI funding of the project ends. We will be doing data analysis and preparations for publications of all the data through the fall of 2018. But very importantly, it's worth noting that UT Southwestern and the TMA has agreed to keep this study and data collection going at a minimum on the online cohort past the PCORI funding. We're going to take this from 120 to 150 to 200 to 300 to 400 kids over however many years it takes us, so we can track and see what the outcomes are over time. This will be a living, breathing entity that goes on through a partnership between the TMA and UT Southwestern. And then it's also worth noting that Capture 2 is in the works, although I'm going to need a new name because the P in Capture is pediatrics, and in Capture 2 we are inviting adults. And the idea is going to be to do the exact same thing on a large scale prospectively around both adults and children. We are still working on how to set that up. So why did I mention the summer of 2014, and why did I point out the seasonal difference? There was an unexpected benefit to having the Capture study up and running when we did. And it had to do with an international outbreak of a variant of transverse myelitis known as acute flaccid myelitis. And just to go through what this is and to put it in perspective of how fortuitous it was that the Capture study was up and running, it's worth noting that in the spinal cord, and on the far right of your screen you see a slice of spinal cord, that the inside of the cord, known as the gray matter, the outside of the cord, known as the white matter, that historically transverse myelitis was thought to be a white matter demyelinating disorder. What we learned over years was that there are a lot of patients who have deficits in both white matter and gray matter, but in the summer of 2014, there was an explosion of kids who had damage primarily to the gray matter, more than the white matter. And this led to what was called the acute flaccid myelitis condition, which is a variant of TM. And what we saw, these are the number of cases reported to the CDC from 2014, 2015, 2016. And without going into details, there is a large focus at the public health level looking at an association with a particular virus that circulates every other year in the United States. And so these outbreaks seem to be correlating with when this virus is circulating amongst our population. So back in the summer of 2014, we were on phone calls with the CDC and we were on phone calls with the NIH trying to figure out how to manage children with this. And they kept saying, you know, we really need to be gathering data, we really need to be gathering data. And we were able to say the Capture study is open for all children with transverse myelitis. And it's actually been, the data we're collecting has been requested for, and we are sharing with members of the CDC and other individuals to help them track what treatments were working, what wasn't. But it's just a reminder to us that these observational studies They may be intended to be used one way, but there's corollary benefits that happen all the time to collecting data in a systematic way. So the last part of this is the partnership with Traitwise, and this was something that Chitra Krishnan and the Transverse Myelitis Association helped us do in a steward. One of the issues with clinical research is we do a very bad job of communicating the results to the world. So we do years of research, and then a paper gets published, and it's got a table with summary statistics, and it says something like, we enrolled 50 people, the average age was 30, 50% were this ethnicity, 50% could walk, 50% could this. And you're sitting back saying, well, I'm 40, I'm this ethnicity, I can walk, but my back, how do I fit into this table? What of this data actually applies to me? So part of the grant through PCORI was to fund an initiative with Traitwise to create an online platform for the future where any clinician treating a child with transverse myelitis can put in information about that child and pull out just the data that applies to kids like that. So instead of going to a table and saying, well, 30% of the boys who couldn't walk, who got plasma exchange, got better, I want just the 8-year-olds who couldn't walk, what happened with the different treatments. And so one of the reasons we're going to keep adding to this database is over time, and this may be a decade or more, and that's fine, we hope this will become a useful tool for clinicians to use when making real-time decisions. So what are the lessons learned from the CAPTURE study? The first, there is no way for institutions, clinicians, or scientists to do these types of things alone. There has to be a partnership with patient advocacy organizations like the TMA. The recruitment has been very educational. It is difficult to recruit patients in an acute event. Tricia Plum, who's in the room, raise your hand. So Tricia Plum has led this entire initiative from UT's point of view. And as you have all been through diagnoses with rare autoimmune disorders, you can think back to those initial days. There's a lot on your plate. There's a lot on your mind. You're worried about yourself or your loved one or your child. And then for somebody to come in or to send you an email or call you and say, hey, would you like to take part in research? You may not be in the best frame of mind to do it, but that's exactly what we're doing. And Tricia has done just an incredible job of making sure we are compassionate and empathetic and understanding of everyone's situation, while frankly trying to balance it with letting the world know how important the work is. We haven't had any better help than from you. So it's amazing when a family, when one of you say to a family, listen, I know what you're going through, but this is something you're going to look back on and it'll be important to you. The sign-up rate is huge. When it's just us, it goes down a little bit, but we are thankful to all of the families and patients who give of themselves to take part in research. This is her email. Feel free to email her on a frequent, regular basis with any referrals. I'm going to keep this up for a while. I can pass out her card and back. Having registries up and running, having a way to capture data, no pun intended, is incredibly important. We never know how it's going to be used. And then it really takes a village. So the CONQUER program, which you've seen referenced in a lot of the slides, as Dr. Harder said yesterday, the C is for collaboration. This is not everybody on the team. I need bigger slides or smaller headshots. But it really takes a very diverse village of individuals to do these types of studies, not just within institutions, but between connecting the institution with those on the outside. So hopefully we will have lots to present about the outcomes data from CAPTURE in years to come with the next symposium. So thank you. And